there's no point at all, in dreaming small.
Hello everyone, welcome back to Lucy's Light. We're joined again by Dr. Kathryn Mannix to talk about end-of-life conversations and to hopefully answer some of the questions I hear time and time again from my followers who are worried, concerned, intrigued about what happens at end of life. What can we do for people nowadays? What matters to people? What matters to professionals in achieving our wishes for end of life? It's great to have you again, Kathryn.
Hi.
The thing for me that I often hear from followers is the fear around the dying process, what's going to happen, how it might be experienced. People are so afraid of a bad death. And what a bad death constitutes is different for everybody, we know, but I think it would be reassuring for people to hear that dying process, what can happen, and reassure them that actually it does follow a particular pattern, as I know you'll share, and that you know they don't need to worry so much about what that looks like, because people will manage that for you.
Yeah, it's a really good question, isn't it? And it's so obviously a thing that you would worry about, partly about what will it be like for me, what will I have to experience, what might I have to put up with. But one of the things that really intrigues me is that almost everybody who I talk to who's now considering what their dying will be like, because it's imminent, like it's going to be in the next few weeks or months, is much more concerned about what will my family see. Is it going to upset my family? Are they going to be left with horrible memories in their bereavement? And it's really interesting how universal that concern is about the people we love more than about ourselves. It's a bit of both. So one of the things that I find really interesting is that everybody's got an idea in their mind of what dying will be like, and it's usually something to do with choking or drowning or going to sleep one night and just not waking up the next morning, even though they were perfectly well the day before. Or it's something they saw on EastEnders or Holby City or in the cinema. And I can pretty much guarantee that it's not going to be like EastEnders or Holby City or the cinema, because they are dramas, aren't they? They are made to be, for some reason we're using death as entertainment, but we do, don't we? And we have zombie movies as entertainment as well. So we like death to be entertaining or funny or scary. But normal dying, which is so much more gentle than that, is really not very entertaining, which is probably why we don't see it on screens. So what I do is talk to people about how when somebody's pregnant, the midwife talks to them about what pregnancy is going to be like, how their body will change, how the baby will grow. They'll have all kinds of scans and checks that the baby's the right size, the right way up, where the placenta is. Now, all of that is so that on the day they go into labour, the baby can be delivered safely. People know which way up it is, which way round it is, how to catch it safely, whether they need to have a cesarean because things aren't lined up the way they should be. And then midwives just follow the process that they see from one woman giving birth to the next woman, to the next woman. And we all know that process because it's on the telly all the time, isn't it? About people's waters breaking, contractions and all the rest of it. So people are quite surprised when they discover that dying is another one of those bodily processes that's got a kind of set of things that usually happens in the same order, a bit like being in labour. So some of them are things that we're already experienced at. So, last time we talked about how if you have the flu, you feel very sleepy a lot of the time because sleep recharges our batteries. So most people who are coming towards the end of their lives, their bodies are getting weary by whatever the illness is that they're dying from. And so they sleep a lot. But when they wake up, unless the illness has in some way affected their mind or their brain, they are just their normal self when they're awake. They like the same things, they've got the same sense of humour, they're pleased to see the people they're always pleased to see, they haven't become pleased to see the people they didn't used to be pleased to see, everything's the same. And as time goes by, we find people just sleep more and they're awake less. And then the time will come, and it would be interesting for you to talk to your palliative care nurse. Is she Bev, your palliative care nurse?
Yeah, and she will have,
yeah, so she will have seen this a lot of times. That a point comes that isn't noticed by the person, but we notice it, where something's changed. And the thing that's changed is we tried to wake them up for something and we couldn't wake them up. It might have been a phone call, it might have been medicines were due, whatever. And when they do wake up later on, they just say, you know, they've had another quite nice snooze. So they don't realise that anything is different. But we know that for a period of time, they weren't just asleep, they were actually unconscious, they were actually in a coma. And what starts to happen is that people during their sleep dip in and out of being unconscious. And so the cycle continues, they're awake a bit, they're asleep a bit, some of the time they're asleep, they're unconscious. And gradually it becomes that they're just unconscious all of the time. Now, a couple of things that are important about being unconscious. One is that you're not going to wake up and swallow your medicines. So if you've got an illness that's giving you a pain or breathlessness or itch, which I know you know how irritating itch can be, you want the treatment to carry on in the background, because if you're coming and going through unconsciousness at the periods where you are more awake, you will still feel the symptoms. We don't want that to happen. So very often we'll switch people across to injections, or you know, in continental Europe they use a lot of suppositories, which you know, for some reason we don't very much like in Britain, or we use little syringe pumps. And they're not different doses of the drugs, they're the same equivalent dose. It's adjusted for being an injection, so they're swallowing it. Once people are unconscious and kind of dipping in and out of their levels of consciousness, we don't want their symptoms to come back, and so we'll find a way of making sure they get their dose of medicine just enough to keep the symptoms from causing them any disturbance. And if we're not disturbed by symptoms, then what will happen is our body and our brain will gradually slip into deeper and deeper unconsciousness. So in the end, the only thing that's still going is the bit of the brain up here at the back that controls breathing. And it just runs on a reflex, which goes between fast and slow and deep and shallow. And it's quite important that people understand and can recognise that, because otherwise they can be upset by seeing it and upset by hearing it. So things like we might breathe with our voice box a little bit tight. And that's not because we're trying to speak, it's just that's the position the muscles are in. But it sounds like the person is making a sigh as they breathe out. Now, if the family don't know better, they might think this person has a pain or they're trying to speak. So it's really important that the people who are looking after that person will do exactly what a midwife does during delivery, which is narrating what's going on. So a midwife is saying, oh, it's this long between the contractions now, and I don't want you to push yet, or right, contractions are changing now, I can feel baby coming down, I want you to pant, I want you to push. We should be narrating dying in the same way as that, to be able to say this is reflex breathing. It might be noisy from time to time, and that doesn't mean that the person's trying to speak, doesn't mean they've got a pain. It might be that some of the time the breathing will be shallow but quite fast, and the person would sound as though they're working quite hard to breathe. It's just a reflex. It doesn't mean they're feeling breathless. And perhaps most importantly of all, generally when we're unconscious and getting ready to die, we're lying down, we're generally in bed, and we're usually lying on our back or kind of quarter turned one way or the other. And it means that bits of saliva and bits of phlegm that have been floating around our mouth can just lie at the back of the throat. Now, ordinarily, you don't tolerate having anything at the back of your throat. You know yourself, if you've got a bit of tea that's gone down the wrong way, you really cough and gag and splutter, don't you, to clear it. But because you're so deeply unconscious that even that bit at the back of your throat that's designed to keep us safe, it's just switched off. It's not talking to the brain anymore. The brain isn't feeling it. So that fluid just lies there. But the breath is coming in and out, past it, up and down the windpipe, and so it bubbles and it makes a rattling noise. And you would never ever hear that noise except a deeply unconscious person. And people call it the death rattle, and they worry that it's fluid that's bubbling up from lungs that are full of fluid, when in fact, no, it's not. There's a tiny amount of fluid just lying at the back of the throat, not disturbing this person at all, telling me that this person now is so deeply unconscious they can't even feel the back of their throat. So if I'm narrating properly, I'm explaining to you that this person that you love is now so deeply unconscious that they are not able to feel even that discomfort. And so that's a reassuring noise, even though it's weird. The next thing that starts to happen is that the breathing pattern starts to change a bit, and there start to be pauses. It starts to slow down. There can be quite long pauses, and then there'll be a breath out that just isn't followed by another breath in. And that's interesting because there's nothing special about that breath, whereas it's always special on Holby City, isn't it? You know, when it's on screen, you know that this is the death breath.
Yep.
And that just doesn't happen. And sometimes we go and find a family sitting around a bed of a person who isn't breathing, and they haven't noticed that they've stopped breathing because it's been so gentle. So that's, I guess, the pattern of normal dying. And then it can be interrupted if the person is unconscious, is uncomfortable. Being uncomfortable drags us back from being unconscious. It makes us alert again. So the other thing that families sometimes will see is the person's a bit more awake, and then the nurses might give a painkilling injection or a breathlessness injection to help the symptoms. And of course, as soon as the symptom gets taken away, that drive to awakeness gets taken away. So the person becomes very unconscious again. And families can misunderstand that they've been given a big slug of something sedative, when in fact all that's happened is their pain was keeping them awake. And by just taking the pain away, they've become much more unconscious again. So this week I had a really interesting experience where I was teaching paramedics about end-of-life care for the COVID pandemic, because they're meeting a lot of people who, by the time they get to the house, are actually quite close to death, and also might be feeling quite breathless, or they might be quite deeply unconscious, but they're breathing very quickly because the low oxygen levels in their blood, that chemical change drives the breathing. And we're talking about being able to manage breathlessness, which we can. Quite small doses of morphine will take breathlessness away. But saying you need to warn the family and the person, if they're awake, that it's only the breathlessness that's keeping this person awake. So when you've managed to swallow this tot of morphine liquid, or when you've had this injection of morphine that the ambulance people are going to give you, it will settle your breathlessness, but it might also make you become not awake anymore. Not because of the drug, but because that's how sick you are. So if you've got important things to say, now is the time to say them. And I know you've talked about how in your own plan, in your own way of what's important, it's the things that are said that's important. It's the things that, the moments that are not lost, to say those really important things. And the things that we see in palliative care are people wanting to say how much they love people, they want to thank people, they want to make up for misunderstandings, they want to say they're sorry about things, or they want to tell somebody that they're forgiven for something. They sometimes want to tell somebody that they're not forgiven at all for something, which is unusual, but sometimes it happens. But mainly it's just about love and reconciliation, and just not taking that moment away from people. If I'm going to give somebody an injection to take their symptoms away, I will always say, listen, I can give this now, or I can give it in 2 or 3 minutes' time. You'll be sleepy after I've given it. Are there things you want to say? I can pop out the room and come back. And so in somebody's house, I'll go and stick the kettle on in the kitchen. If I'm in the hospital, I'll go and see another patient and come back, or I'll just go and talk to the nurses about what we're doing and come back, so that we're not leaving them with symptoms for a long time, but we're leaving the family to be able to say their goodbyes, because it's a precious moment, isn't it?
It is, and I think it's, again, giving people that time and that opportunity, isn't it? It's saying, I can give you this, but it might mean that obviously that symptom will go, you will then become unconscious, but now's the time to say what you want to say, and you allow people to do that. And that might be phoning someone abroad on an iPad, it might be, you know, sitting with their daughter, it might be someone giving them a hug. I know that's quite a lot of the parents that I know of children with very complex needs. The thing when they die in an ITU is they don't get to hug their children like they would at home. And that means more to them than anything. And you often hear about, you know, intensive care staff moving the person over and allowing their loved one, their partner, their girlfriend, whoever, to lay next to them. Because it's that last moment they could do it. Yeah, it's that last moment they could do that. And I think it's not always spoken, it's what matters to that person, but it's, again, that permission to say, we need to do this now. We need to manage your symptoms, we need to look at the situation, but if you want to do something, it needs to be now, and we will help you and we will support you. But for me, example, I'd probably want my mum to climb in bed with me and cuddle me, because we don't get the opportunity. Now I struggle to move. when I'm like, just full stop, but especially when I'm in bed, obviously, you know, we'd have to get 2 people to hoist me over and stuff like that, but that would be the last chance my mum would get to hug me alive. And I'd want that opportunity, but they could do that when I was unconscious, but I'd want to be able to reciprocate that hug and feel it as well.
Yeah.
So it's about giving that opportunity.
Yeah, it is. It's very important. And one of the things that I found really interesting is you talking about your followers asking you about these things. I got readers who write to me, and I've lost count now of the number of letters and messages and social media, and people have written to magazines where I've had an interview and they've got the message to me that way. People are very creative, but there are two really, really clear themes coming out. And one is people who are themselves sick, who know themselves to be dying, who had imagined that dying was so much worse than what I'm describing in the stories that I'm telling about people who happen to be living while they're dying anyway, but also describing dying in some detail. But perhaps even more poignant than that, the number of people who've written to me to say, I heard those noises, I watched this beloved person, I thought they were in agony, I thought they were drowning, I thought they were sighing, I thought they were groaning. And now I've read your book, I realise that actually they were unconscious, that these were the reflex breathing noises, that they were probably completely comfortable. And I've carried that, sometimes, some people for decades, I've carried the horror of that. And how awful for those people that nobody got beside them at the time and said, this is what these noises are, this is what's happening to your parent, to your spouse, to your child. And you can sit here, you can hold their hand. That's something we know from intensive care units where people have had quite serious head injuries is, although they appear to be completely unconscious, they do seem, or some do seem, to be able to hear. And when they regain consciousness, they can tell us whose voices they heard, for example. It doesn't happen to everybody, but it happens often enough that we always make the assumption that anybody who's unconscious in terms of they're not feeling their throat or they're not feeling their body might still be hearing. And so we talk to them when we're moving them in bed. We encourage their families to talk to them as well. And to be able to know that you were sitting there chatting to this person, they were deeply unconscious, the noises didn't mean they were sighing and groaning, but they quite probably could hear and take comfort from your voice being beside them. I think that's just so important.
Yeah.
So we need to be training doctors and nurses and paramedics and all of these people. Yes, of course, we've got to train people to save lives. That's what most of us train to do. But all of us will also come across end of life, and we need to be able to describe it and allow the people who are witnessing it to not be further traumatized by misunderstanding what they're seeing and hearing. It's sad enough that somebody that you love is dying without you believing that they're in torment at the same time when they're not.
Yeah.
So really, really important part of training, isn't it?
Yeah, it is. And it's just, again, that reassurance, that kind of permission. And I know a lot of people that I talk to are really worried they're going to die on their own because they hear stories of, and people, their family will be with them for days and then they leave the room and then the person dies. But when my nan was in hospital, one of the nurses that was looking after her did say, the palliative care nurse did say, she finds that men tend to like to have people around them when they die, but women are the type of people that will hang on and hang on and hang on until that person has left, and then they'll slip away. And it was certainly true of that with my nan.
That is so interesting, but we do see it far more often than can just be by chance. The families have been around that bed for days, and the 30 seconds that one person had gone to the loo and somebody else's phone rang and they went out so they weren't noisy and the person stops breathing. Again, why is that? We just don't understand it, but all of us who work in end-of-life care see it so often that, in fact, when people are admitted to hospices, very often hospices will warn the family this might happen. Maybe some people just need to be on their own for that final moment. Maybe there's too much love in the room to let go. I don't know what it's about.
It's a bit like a lot of people waiting for that permission, isn't it? they'll wait for someone to say
Yeah.
to them it's okay to go. I think
Yeah.
everyone's different and everything's different, but it is almost like some people just need that space. Some people just need the permission. Some people just need to know that that one person that they love so much has been present. But you know, we don't know. We know so little. But I think it's just reassuring people that things will happen as they happen. But you know, what will happen will be whatever your body and you need and what works for you. But it might just be by chance. But those people have been there. You've said what you wanted to say. You can be reassured that, you know, at that point you're not suffering. You know, you're very unconscious, and it just, things don't happen by the rule book. It's a bit like births. You know, not every birth goes by the birth plan. We have to be prepared for those unexpected and, you know, unknown moments. But what's important, I think, for me more than anything is, rather than being there necessarily at the point of death, is in the build-up, when you can say those times and you can have that quality of time. That's even more important, I think, for end of life kind of things than it is about dying, because that person is so at peace, they will just exhale, they will just slip off. But actually that time building up to that is when it's most important, I think, to focus on.
I think you're absolutely right. And I think that's been the difficulty with the COVID epidemic, hasn't it? That because of infection control, people have been separated from each other anyway because of lockdown. And then somebody's sick and they haven't seen people, and the next thing they're towed off in an ambulance. And then for a period they weren't allowed visitors. They can have our visitor now, can't they, if they're so sick that they're thought to be possibly in danger of dying. And certainly if they need a personal assistant, they can have their assistance for movement or for sign language or whatever it is they need. But we've got a lot of families who've been separated from people who they didn't think were in danger of dying, who suddenly got sick and have died. And one of the things that we do in bereavement is we tell the story of the dying to help us make sense of it all. Who came on what day, what they said, did he have that cup of tea? He never did finish that cup of tea, or that was the last thing he drank, and the last thing he said was, and so on and so on. And we can't construct those stories either for the deaths in hospital or the deaths in care home lockdown. And there are people, of course, who are dying not of COVID, but during COVID, who also can't have companions. So I've heard some hospitals are keeping bedside diaries for patients, which they can have when they go home if they get better. But if they don't get better, they've got a record for families of, you know, this he was awake at these times, and this is what we helped him make the Skype call to whoever. This was the last time he had a drink, and just to help people to start to be able to tell the story and get into their pattern for bereavement. It's been a very hard time for people. I think.
And I think those diaries, they take on a different meaning if the person survives. That's a narration to the person of what happened when they were unconscious. And if they've died, it becomes their family's kind of their last kind of wishes. And I know my mum said she wishes they'd kept a diary from when she was in ITU, because she could remember bits. She had these hazy memories. She can't make sense of it. And I think, but equally as much, if my mum had died, I think I would have found comfort in that diary from the nurse, because I saw her for 2 hours a day. I wasn't there the rest of the 22 hours a day. I would have found that comforting. And during COVID, it's just not, there just isn't that. There isn't the nursing ratio. There isn't the time. There's so many constrictions. And I just think, you know, it must be so awful to lose your loved one at this time, to not be there, to not be able to travel. Or I've had a friend that lost someone close to them, and she couldn't go to the hospital because she had to shield because she was at high risk. So it wasn't even that the hospital wouldn't let her in. She couldn't take the risk of going into the hospital purely because of COVID.
No, it is a terribly, terribly difficult time. And yet at the same time, things are happening that you and I 6 months ago would never have predicted. People are talking about dying. Newspapers are talking about dying in the news. And to start off with, it was just numbers of deaths, wasn't it? We didn't actually talk about people. We just talked about data. But now we're actually talking about the experience of dying. We're talking about bereavement. People are trying to keep diaries. They are trying to find ways of connecting people electronically from their hospital beds. There are some changes in the way we're providing healthcare that I really hope we'll hold on to when we come through the other side of this.
Yeah.
And one of them is the public conversation about dying. And one of them is the public conversation about planning ahead, and the idea that you can talk to your families about what your wants and wishes are, because it's so important.
Yeah, and I think the thing about advanced care planning as well is you kind of need to do different things for different things. So, you know, it's no good just having a conversation and not putting in place a lasting power of attorney or advanced decision. It's about making best use of what's available to make sure that, you know, your wishes at the end of the day are central to any decision making that's happening. So if that's an advanced decision, if that's a lasting power of attorney, if it's having the conversations, you know, it's all these things that fit together in a kind of a jigsaw puzzle. Again, it's giving people the tools, letting them know that they exist, but also the permission to say, actually, you can appoint a lasting power of attorney, but say, actually, in terms of life-saving decisions, my advanced decision will cover that. So you can make it work for you. And I think I obviously do a lot, as you know, do a lot of work in personalised care and personalised end-of-life care, and that is all about building it around the person. And when I build the care plans for my clients that I do brokerage for, it is very much making use of all the resources available. And I think with end-of-life and thinking ahead, we should also be encouraging people to make use of the things that make sense to them. They might really, really, really want someone to know how they like their tea or what food they like. Well, an advanced statement can easily just convey that, or a preferred priorities of care can just record that little bit of information that matters to them. Or, you know, for someone like me, I really would not like to die in hospital. I'd like to be at home, but if I can't be at home, I'd rather be in a hospice. And that's now recorded. You know, it's about making use of what's there to make it work for your needs. And I think, I hope this talking about dying, this national conversation will start to make people think, actually, there's a next step to this that can mean that what I want can be understood by those that are caring for me at the end of life. Because that control, people that need control, and advanced care planning, it doesn't give you ultimate control, it doesn't, but it gives you some control over that process and what happens. And, you know, I have had so much loss of control in my life that being able to do my advanced care plan is a way of controlling my end of life. Not in the fact that I control what happens, how it happens, when it happens, where it happens, necessarily, but that I know that whoever is making those decisions knows Lucy's wishes, and they're Lucy's wishes in Lucy's words. So my mum can convey them from her perspective, but these documents will also say, I am me, this is what I want, and this is what's so important to me, because I have had so many decisions taken away from me that it's important that people hear things in my words. It's what I've said. It's not what someone's relayed what I've said. It's what actually Lucy has said, and it's in that document, and it tells people so clearly they know what I want, and they can grab the essence of who I am and why that matters to me as well.
Yeah, and I think that's so important. Absolutely right.
Yeah, and I mean, thinking about kind of other things that I get asked, a lot of people tend to worry about family members when they're broaching these end-of-life conversations. They're worried of offending people, they're worried of upsetting people. And I think you and I have, in our previous call, both said about, you know, it is an act of love, and it is an act of compassion, and it is an act of hope. And I think these people need to think about, you know, talking about dying is a positive, not a negative. It might be hard, it might be messy, it might be, you know, really difficult, it might be full of tears and snot and God knows what else. But the fact is, it's so important, and you can do that for the people you love. You can have those conversations, because one of the things that I see is when people have got regrets about, you know, saying yes to an intervention for their loved one, and then their loved one, you know, actually when their loved one is living on that ventilator, or actually thinking, you know what, I shouldn't have done that, but because they were so desperate in that moment.
Terribly, terribly difficult, isn't it? And again, people need to be able to cut themselves some slack that they've acted out of love, haven't they? They haven't acted out of malice.
No, not
but
at all.
It's just so much easier if you know what the person wants, and if the people who are making the medical decisions ask their questions properly. And so again, we've got to help doctors to be really clear that what they're saying is not, Lucy's mum, what do you want us to do? what they're saying is, Lucy's mum, what would Lucy want us to do? If we could sit Lucy up now and have full 100% Lucy back for 10 minutes, what would she say?
Yeah.
So that people aren't left thinking that they have made a decision that wasn't theirs to make. Because unless, you know, as we've discussed, unless they've got lasting power of attorney, it's not their decision to make. And even when it is their decision to make, the decision we're trusting our attorneys to make is our decision. This is what I want you to say on my behalf under these circumstances. Yeah.
Yeah, but I think we've covered quite a lot over these last 2 calls. So I really thank
Certainly
you.
have.
You know, thank you for coming on and for talking with me. And it's always great to talk with someone that, you know, kind of thinks the same way about these kind of conversations and that shares kind of my ethos about this. But also, it's just nice to have a cup of tea, have a chat. And thank you really much for appearing on it. And I
It's
hope
been lovely.
and I hope people will check out your book With the End in Mind. I mean, I've read it a couple of times now because I just enjoy it. It's just so reassuring, I think, hearing those stories, seeing that narration of death, it brings comfort. And I think With the End in Mind is a book that is not only about sharing the stories you share, but it's about giving back to people. And I think people need to read that as a way into these conversations, to understand that it is normal, it is natural, and that it can be comfortable. And I hope that's what people, I know that's what people get from your book, but I hope people that come to your book will see that this is not about just them just reading a text and then leaving off and going off and carrying on with their life. This is about changing their perception and giving them that permission to talk about these conversations.
Well, I would love to think it's having that effect. So thank you very much for sharing your passion. And here's a cup of tea. Good health.
Thank you.
Bye, Lucy.